So it's like a organ, yeah.
Hello and welcome from Denver, Colorado at ARVO 2022. It is great to be here in person and to see the hundreds of people here. It's 3 years ago since the last ARVO meeting in Vancouver. So it is wonderful to see everyone here, and I'm delighted to have with us today Dr. Wendy Harrison. Dr. Harrison is an optometrist who practices in Texas, in Houston. And she did her optometry degree at the Indiana University School of Optometry and her PhD at Berkeley. So it's really appreciate you taking the time to be with us today and to share some of your experiences with patients as well as with the RETeval device. And so, you know, tell us a little bit about your practice and the type of patients you see, in your practice.
So I run the clinical electrophysiology for the University of Houston. So my practice is almost entirely ERG based. We do a lot of ERGs, EOGs, VEPs, multifocal ERGs, pretty much for the entire Houston area as well as Western Louisiana.
Awesome.
So.
And can you tell us a little bit about using the RETeval in your practice, the handheld electrophysiology device?
So the big thing that the RETeval has done for our practice is allow us to expand the age range of the patients that we see. So I typically, for my older patients, use a Allen electrode, but there are a lot of patients out there who cannot wear a Allen electrode. And these are, especially, children and special needs patients who I see now more frequently in my practice because we have the RETeval as an option for them to get high quality ERGs.
Okay, and what is it that you're looking for when you're using the RETeval device? What indications tell you that you really should do an ERG and that perhaps RETeval is the right answer to do the ERG in your lab?
So almost all of my patients have an ordered ERG that's coming in from a retinal specialist or another optometrist. But I also do see a lot of unexplained vision loss patients who kind of the discretion of what testing they need is up to us. So really, we're looking for patients who have, night blinding conditions or, some sort of other field change that could indicate that they have a rod-based problem. And I'll use the RETeval if it looks like it's going to be the better instrument for that particular patient. So anyone under 10, definitely, as well as a lot of the special needs patients that we see. If they can't get an eye drop in easily, if they can't handle us touching around their eye, then usually they'll get much better results with the RETeval than from us trying to manipulate something into their eye.
What's the youngest patients that you've used the RETeval on?
The youngest patients I've used the RETeval on are about 5 years old.
Okay.
So, and if we weren't able to do that, they'd have to do their exam under anesthesia. So I do feel like there's a real added benefit to using the RETeval on kids that age.
Okay. Plus, you give immediate results to the family.
Exactly.
Rather than waiting for scheduling the OR and coming back.
Exactly. And as a parent, I know that I wouldn't want to put my children under anesthesia if there was a way to get the test results with them, being awake.
Okay. And what are some of the challenges that you face testing younger patients like that?
Probably the hardest one is just we do a 20-minute dark adaptation. And there are a certain number of kids, even with their parents, who aren't thrilled about sitting in the dark for 20 minutes. So that's a little bit of a challenge. And then too, little kids are just more wiggly. So, we're, kind of chasing them around with the instrument just a little bit and trying to make sure that we get really high quality recordings. Usually I have to record a couple of times, but I have always been able to successfully get good ERGs for them.
And what protocol do you typically run when you're testing these children?
I use the standard ICEV, dark adapted and light adapted ERG protocol.
And typically, what are you looking for in utilizing these? What are you looking for in these patients?
So in almost all my patients, we're trying to rule in or rule out retinitis pigmentosa.
Okay.
Yeah.
And that's a tough condition.
Yeah.
I'm sure the family likes when you rule it out.
Yes, definitely. I've seen had a lot of referrals recently for children who are very high myopes, where they're concerned that they may have, some sort of syndromic type, retinal condition, that, they just kind of want to check and make sure everything's okay.
Okay. And what tips and techniques would you have for people who are using and performing ERGs, especially on children, down to age 5 or younger?
So I think the big thing is just to be patient with the kids and kind of show them, what's about to happen as it's going on. So usually I like to show them the stickers that are going to be on their face, let them kind of touch them and see that, they're plastic, they're not going to hurt, those kinds of things. I feel like they do better, right, if I can show them what the device looks like ahead of time before they go into the dark room. They can see that I'm going to hold it up in front of their eye, that it's not going to hurt them or anything like that. So.
Okay. And, I guess one question would be, of all the patients you've tested and you've used the RETeval device, is there one that sticks out in your mind that this device really helped you in terms of determining what was happening in that patient's eye?
Yeah, so I had a little boy. He was probably 6 years old. He was a -12 myope. And, there were some questions as to whether or not he was having, difficulty with his vision or not. And with the RETeval, we were able to see that his rod-based function was normal, but his cone-based function was not normal. And so from that, we knew that we needed genetic testing and a couple of other, kind of follow-up tests to really see what was going on with his vision. But I think having that kind of early electrophysiology finding that his rods were normal, but his cones weren't, are going to ultimately allow us to get his correct diagnosis.
Okay. If you were talking to someone who perhaps didn't have the experience level you have with electrophysiology, but had an interest in basically starting electrophysiology, perhaps using the RETeval device, what would you tell them? I mean, what would you say to them?
So I think, electrophysiology is one of those things that sounds tricky, but if you, kind of follow through with the protocols and, really look at what the different conditions that you're trying to rule in or out, look like in an electrophysiology signature, it is something that can be done in most practices. So I think that, if people have kind of the right books and the right, things to really be able to follow up on some of these conditions, the test itself isn't difficult to perform. You just need to have a space to perform it and kind of the ability to control the light. And in optometry and ophthalmology practices, we're pretty good at controlling lights.
Yeah.
So I think it is feasible for people to do.
Okay. And, how easy or difficult would you say the RETeval is to use for someone who may be a tech or maybe a OD or an MD who doesn't have the experience, and how difficult is it to get up to speed and learn?
The instrument itself is very user friendly and easy to use, right? So you just have to, make sure you put the electrodes in the right location. Make sure that they're sticking well. Exfoliate the area where they need to stick. Kind of even better than you think that you might need to. And then you really just follow the prompts, right? So you have to pick the right test that you want to do. And then, you hold it up and it tells you exactly what to do. So, you don't really need to worry that you're going to, have the wrong flash go, because, it's all built into the instrument.
What about the reporting and interpretation of the results, which is always a concern of people who are just getting into electrophysiology?
Yeah. So I would say that if you know that you did a good job recording the test, the printout is also pretty easy to read. So it's color coded, much like an OCT. And so you can kind of use the color coding to get an idea if the tests are in the normal range or not. So I don't use the color codes a ton myself. I kind of look at, where the troughs and the peaks are located as far as, I think that the tests are normal, but it's great to have those built-in normal values to be able to compare to. And I think kind of early on, having that built in would make the test easier to interpret.
Okay. Well, I thank you for joining us today. And I also thank you, more importantly, for all you do for the patients and the children that you see in Houston. I'm the father of a totally blind son from ROP, actually. He's 42 years old, so he's been around a while. But you know, I truly understand how important it is, the work you do and the impact that you make on the lives of many, many people and parents.
Yeah.
So thank you.
Well, thank you for having me. I'm thrilled to be here at ARVO in person again. And I'm also thrilled to have the opportunity to use the RETeval to help children in my practice.
Great. Thank you very much.
Thank you.
And have a great rest of the meeting.
Yeah, you
Enjoy.
too.
Thanks.
Thanks.